All right, I think we can go ahead and get started. This week we're going to be talking about extravehicular activities, and then we'll be ending with a student presentation by Mimi on the cardiovascular system. With that, I'll go ahead and enable screen sharing. And Dr. Buckey, the floor is yours.
Okay, well, great. Well, thanks very much. And there we go. Does that say EVA? Yes. Okay, so I know the title is called Cardiovascular and EVA, but I think I've talked about some of the cardiovascular things earlier. We talked about hydrostatic gradients and what happens to central venous pressure in space, and some of the unique cardiovascular effects of weightlessness. And I think Mimi is going to get to some of those later. So I was going to focus on some of the unique physiological challenges, well, not necessarily unique, but some of the physiological challenges that extravehicular activity working in a spacesuit present. And I'll start off with a little story. So the very first EVA kind of highlighted almost all the issues that you can have during an EVA. So it was Alexei Leonov left his Voskhod 2 capsule in March 1965 to begin the first spacewalk ever performed. And so all went well until he tried to get back into the capsule. So his suit was pressurized to 5.9 psi. And so he had difficulty maneuvering because when the suit is pressurized, you have to then work against the pressure in the suit. So he reduced the suit pressure to 3.7. He had the capability to do that, which made his suit more mobile, but also increased his risk for decompression sickness. And we'll talk about that in a moment. His efforts to get back inside the capsule generated more heat than his suit could remove, causing his body temperature to increase, his heart rate to rise, and his visor to fog. So, he's getting into a pretty bad situation where it looked like he might be exhausted before he could get himself back into the capsule. And so even though his spacewalk lasted only 12 minutes, by the end, Leonov was dehydrated and physically exhausted. And the Russians didn't really publicize this. And it turned out that the first spacewalk in the US program by Ed White had a very similar outcome. It was really difficult for him to get back into the capsule. He got overheated, his visor fired, the whole thing. But what these stories indicate are a couple of major risks with EVA. One, heat stress. So you're working inside a suit. So all the heat that your body generates, which ordinarily here is going to be helped with evaporative cooling, has to be taken care of by the suit. The other is that you're in a low pressure environment. So we're talking about the risk of decompression sickness. And so that's, something that you don't usually have to take into account just in day-to-day activities. And then also just the training that has to go into being able to take this on. And we talked about a couple other things earlier. We talked about the risk of vomiting in your suit, and also the idea if you don't want to get anything loose in your suit that would compromise your vision. So I just wanted to give you a little breakdown of the oxygen cost and heat production of various activities. And so on the left here, we see the activity like walking or golf, cycling, playing basketball, and wrestling. And you can see it gives you a rough oxygen uptake for that, how many liters per minute of oxygen you have to take up, and then how much heat that produces in kilocalories per hour. And the reason why this is interesting is that the suit, or at least the current extravehicular mobility suit that, at least at the time I wrote this, could handle about 252 kilocalories per hour continuously, peak to 403, and maybe it could do 503 for 15 minutes. So as you can see, that's above slow, that's in between, for regular activity, it's between slow walking and golf. So the fact is you can't really get yourself doing too much work inside that suit, or you're going to very quickly overtax the suit's ability to take that heat away. So that's something about working in a suit like that. Now, the other thing is that at least right now, the International Space Station is at cabin pressure of 1 atmosphere, or 14.7 psi, or 760 millimeters of mercury. So that's the standard pressure that's in the space station. And that's the pressure we're at right now. So being at 1 atmosphere of pressure, we're essentially in this sea of nitrogen, since, almost 80% of the gas around us is nitrogen. So this nitrogen has equilibrated with our bodies. And so there's a sea of nitrogen around us. There is also nitrogen all through our tissues at equilibrium with the amount of nitrogen that's in the atmosphere. So that's fine, except what if we were to suddenly reduce the pressure around us? So here we're at 1 atmosphere. What if we were to instantly take us to the top of Mount Everest, where where the pressure is much lower? If we did that, now the partial pressure of nitrogen outside of us has gone down dramatically by more than half. And this nitrogen that's in our body wants to come out of solution and equilibrate with the nitrogen in the gas around us. So the way to think about this is like if you have a bottle of soda and you take the cap off, you'll see bubbles come out of solution, because when you take that cap off, you release the pressure that's in the air above the soda. And once that pressure is released, then the gas can come out of solution. And this is an echocardiogram that is from a study with a swine model. But this is a pig that had been at depth. Actually, it had been a higher atmospheric pressure and now was coming back up to the surface. And you can see what's going to happen here. So that's an echocardiogram of the heart. And you see all those little things coming through there? Oh, that now looks like it's totally blacked out. All those moving, those. And so what's happening is that this is bubbles of decompression. So the pig has been decompressed to sea level pressure, and now all this nitrogen that had been in solution now wants to come out. And it's showing up as bubbles inside the bloodstream. And for those of you who are familiar with who are divers or have done scuba diving, know that if those bubbles decide to come out of solution in a joint, it gives you the bends, so-called, because you feel like you have to bend over because the pain is so severe. So it's very common, maybe in the shoulder or a knee, for you to get pain due to the gas expanding as you come to the surface. When we think about divers, they're going from a high pressure back up to sea level. Here, we're talking about going from sea level to a low pressure. And this is what it looks like at, this is a severe case of bubbles in the bloodstream. And you can see what looked those little silvery dot things there. Those are actually bubbles, gas that is kind of in the bloodstream from a decompression event. So you can see that not only can the bubbles travel through your bloodstream without causing problems, they can also create a brain. You can have stroke symptoms. If it goes to the spinal cord, you can get paralysis. And so bubbles and decompression sickness is something that you really want to avoid on spaceflight. So what are some of the pressures of interest for EVA work? So I was talking about a pressure at sea level is 14.7 psi, or 101.3 kilopascals. If you go up to, let's say, 11,000 meters, then that's kind of where you can start to see a threshold for getting DCS, or decompression sickness. And as you go higher and higher, you can see that you'll start to see VGE, which is venous gas emboli, or those bubbles that I showed in the heart. And then you start to get DCS, or decompression sickness, starts to happen. And what this says here with no pre-breathing is something else that you can do. So what you can do in order to help prevent decompression sickness is that before you go to altitude, you breathe oxygen. And this was something that was started back in World War II, when the bombers that would fly on high altitude missions were unpressurized. So what crews had to do before they went on these missions was to breathe oxygen beforehand, let nitrogen come out of their body, and then they could go on the mission safely. And so the same thing has to happen on the space station. If you're going to go from being in the space station at sea level pressure and get into a low pressure suit, then you need to pre-breathe oxygen. I actually think there's an error here. I don't think this is meters, that should be feet, but I'll check on that. Another issue that comes up with bubbles is what if, those bubbles that are going through the right heart that we saw in that echocardiogram earlier, what if those bubbles made it to the left side of the circulation? So, because we know that a lot of people who dive, you'll be able to detect bubbles coming through the heart. But that doesn't mean everybody is getting an embolus, or they're getting paralyzed, or they're having stroke symptoms, or they're having anything. So there's a lot of times that people get bubbles in their bloodstream, and they seem to have no adverse effects. They seem to be rapidly cleared by the lungs, and they don't stick around. And a lot of people get bubbles in the bloodstream, and you can't really tell if they've had any bad effects from it. But what if those bubbles passed from the right side of the heart to the left side of the heart, got pumped out through the aorta, up through the carotids, and into the brain? And what that can happen with is a patent foramen ovale, so a little hole between the right and left atrium. And in that case, bubbles that are in the right heart can pass over into the left heart, and then might cause more problems. And this is always an ongoing debate in the diving community and with space activities, whether it's safe to have a PFO and fly or not. And lots of people have had PFOs and have had no problems with diving, but there is some evidence that there is some risk associated with it. This was a study that was looking at the odds of severe decompression sickness in divers who had a major right to left shunt, meaning that the gas could get from the right side of the heart to the left side of the heart. And they were looking at how many people, like here's limb bends, which means having like pain in a shoulder or a knee. And that didn't seem to be any greater in people who had a shunt. But if you look at things that happen in the brain, like cerebral DCS or cochleovestibular DCS, meaning to the inner ear, there did seem to be a stronger association with having a patent foramen ovale. So one thing that will always come up is whether people should be screened for this, whether it should be corrected. And there's no easy answer, because the risk is not high, even though it does seem to be higher perhaps than if you didn't have one. And having surgery to correct it is not risk-free. So, but that's an issue that always comes up, is whether right to left shunt needs to be investigated in people who are going to do EVAs. So there have been other EVA events that I didn't talk about. There was on the space station, a very scary situation where there was a leak of water into the suit from the cooling system, leading to a near drowning. That an astronaut, you can have him tell his story. It's really quite scary that the water was just, because it's weightless, it's floating up around his face. If it had filled the suit, he could have drowned, and he was outside the station at that time. Fortunately, his crewmate noticed that he had this problem. They were able to get him inside and deal with that before he had a serious problem. And then the other thing I didn't really talk about, but working against that suit, remember the suit's pressurized, so working in the suit requires a fair amount of effort, and there are a number of shoulder and finger injuries that come from working against the suit. So making it easy for people to do EVA is difficult. That working against the suit is challenging, and then there are these other issues that have to be taken care of as well. So just for fun, I thought I'd show you some videos from the Apollo program that shows what it's like to do moonwalking. So this is the only case we have where we have people walking on the moon, and you can see what it's like to be in a spacesuit walking on another planetary surface. And there are, several things that need to be taken into account when you're doing this. And I wanted to thank John Clark from Baylor, who had put these videos together. So this is just a little video that shows you what it's like to walk around on the lunar surface.
Measured, height. You got all the shields. You're coming out south. Verify heat flow is level and aligned. It is aligned. The Noman was good. UHT to the LRV, LMP seat, and then what do I do? Let me see.
And he doesn't need to carry that UHT
Deep
back.
core prep. Jack, I'm going to leave the UHT in the heat flow in case you need it. Okay. Okay, I'm going to go behind a rock over there.
So I don't know if you noticed, but he's kind of doing this kangaroo hop because he weighs only about 1/6 of his Earth weight, and then we have to add the suit onto that. But instead of doing it like a regular walk or run, it's kind of this hopping sort of kangaroo hop in order to get around on the surface of the moon.
Measured, height. You got all the shields.
You're doing some work.
You're saying they can use a wrench and unscrew.
Do it clockwise.
Yeah.
It's better than the treadle flying down.
Skip. Right, they say give it a slight rotation clockwise and lifting out.
Okay.
EVA flight.
Stay there.
Go flight. Did you copy what else I'm saying here? Yes, I did.
So there you can see the other problem is if you fall, it's a little bit challenging to get up because you got this huge backpack on you. And so it kind of pins you on your back if you fall on your back. So it's hard to get up sometimes if you fall wearing a suit like this, even though you are in a low gravity environment.
You're saying they can use a wrench and unscrew.
Hey, John, while you're sampling there, you might look around and see if you see any of that vesicular basalt. That's what I'm looking for. Good show. I told him you were. Whoop. Okay. We see that one went all the way in. Not quite.
Wow.
But there it is, all but about 5 inches. Okay. And that one was... Okay, and John, stand by for a feed water tone. Just got it. How's that? The hope.
So that was kind of difficult to watch just because he fell forward. And then if you notice, he had to do this several sort of push-up maneuvers to try to get back, and which all worked out. But, if there had been a rock there and what missed on one of those pushes, it could have had the rock go right through the visor. So fortunately that all worked out okay, but you can see it's not guaranteed. Woo. And then it's another instance where you kind of, you get going so fast with the kangaroo hop and then fall forward into the spacesuit. So I think I'm going to stop it there and just give you a little introduction there to EVA. So that's just kind of a little thumbnail sketch of some of the issues with EVA. It's very important to remember that you can generate more heat than your suit can take away. That being able to operate in that suit, it's an issue with balance, that has to go, a lot that has to go in time. And then there's always that risk of decompression sickness, which is going to drive to how you design a habitat or someplace on the moon or Mars, because you don't want to be constantly going between different pressure environments. If you want to do a lot of EVA, you want to kind of be in a pressure environment that allows you to go in and out very easily. And I guess the extreme of that, just one last thing, is that the space station is at 1 atmosphere of pressure with a 80% nitrogen, 20% oxygen atmosphere. The Skylab was at 5 psi and it was 100% oxygen. So that meant that they didn't have to do any pre-brief to go outside and do a spacewalk. The habitats for Mars and Moon are going to be somewhere in between there. So that's, and we'll talk about that in a later talk. But that's what I've got for EVA, and happy to we can move on to what Mimi has, or I'm happy to take questions.
All right, sounds like Matt has a question. Go for it, Matt.
Yes, thank you, Dr. Buckey. Really, really fascinating talk. Thank you. I just had a quick question about an astronaut's ability to kind of like develop these decompression sicknesses even after having multiple EVAs. Is it pretty much all preventable by the tasks or preventions that they do before and during and after the EVA, or does it have any effect on whether the astronaut has done multiple EVAs or kind of like train their body to adjust for those?
That's a great question. So some people seem to be at higher risk for decompression sickness than others. People who are older, who are heavier, they tend to have a higher risk of getting decompression sickness. However, it doesn't seem like that you can have done, several usually decompression sickness is a lot more common in diving, but you can have done a lot of dives and then all of a sudden show up one day and get decompression sickness. So there's a statistical aspect to it where it's not either yes or no, depending on who you are. There's a statistical component about whether you're going to develop decompression sickness. So that's how all dive tables are designed. They're designed to allow a set rate of decompression sickness. So they're not 100% safe. It just means they're safe enough so that you can operate with a very low likelihood of somebody get decompression sickness. I hope that, puts it in perspective.
Yes, thank you.
Go for it, Jerry.
Hi, thank you. So remember I told you I used to work as a boat captain. I used to work on dive trips, actually. So it was these outdoor adventure. One of the things I used to do was these outdoor adventure programs where kids would learn how to dive. And
oh my gosh.
That's where I learned how to dive.
So, yes, you've got this great background, I'll tell you.
Yeah, well, it's interesting to hear these things from a space perspective. So yeah, with diving, obviously all these dive tables are pretty worked out. You follow these rules, you don't get decompression sickness. At least that's how it's always been pitched to me. And that's how, the dive classes, teach you. So I'm wondering, is it obviously, but that I believe was developed with lots of Navy participants. I think back in World War II era, they just had people dive down and see, I think when they got decompression sickness is my understanding, at different pressure levels. And so I'm wondering if there's any sort of like dive table equivalent for spacewalks. And then if there is, like, what pressures, if the pressures would differ, for example, in your story, you had, I think, like 5.9 PSI, and then the person went to 3.7 PSI. And I'm wondering if those pressures have changed over time as the spacesuits have potentially changed. And then I guess another question I'm curious about is if there's like a nitrox equivalent. So one of the things I did was, I got one of these nitrox certifications where you can dive with basically special mixes of gases that prevent that. So I guess, the comparison there would be if you had gas mixtures that would just be, for the suits, but you wouldn't have to have the whole space habitat or the whole, let's say like Moon or Mars habitat at that mixture of gases, but you would just breathe it while you were, I guess I'm seeing the problem with that now. It's that you're in the most compressed state in the habitat. So that's where you need to be breathing those gases.
Yeah. Yeah. So yeah, it's like, it's sort of like being in the habitat is when you're diving, and
Yeah.
then when you're in the suit is when you're coming up to the surface. The
I don't know if it's just me, but
There hasn't really been dive colleague. Oh, hello. Can you hear me now?
now I can.
Okay. Yep. So a colleague, Richard Moon, and his colleagues at Duke, and also astronauts, worked on this in order to figure out how safe was it to go and use different pre-breathe techniques in order to go on a spacewalk. And so they did this on Earth, where they would have different pre-breathe periods, and then they'd have people do exercises that simulated what you would do on an EVA, and then they actually looked to see what was the rate of the development of decompression sickness. And from that, they developed the in-flight pre-breathe protocol that's currently in use, and which involves pre-breathing and a little bit of exercise. That the exercise helps to get the nitrogen out of the body quicker. So that's the current thing that's done right now. The idea in the habitats, the habitats will kind of be like nitrox in the sense that it's going to be, so nitrox gas mixture, less and more oxygen than you get right now with, just breathing air. And so it's got more oxygen, less nitrogen. And so the habitat volume is probably going to have that. So the less nitrogen you have that putting in people, the less nitrogen they have to get out. So that will be, but there'll always be some, because there is this concern that there's a fire suppression improvement that comes from having some inert gas like nitrogen in the mix.
Thank you.
Hi, my name is August. I have a question, just kind of related to, you kind of mentioned like the EVA, the shoulder and hand injuries, and it's related to that. I'm an occupational therapy student, and that's kind of one of the topics I've been looking into for my doc project. So my question is, so obviously we all know time is money, and so they try to limit, some of the medical officer training that they have done in the past, and that's
Right.
included like less therapeutic interventions, like a smaller amount of time with covering that. In future missions, my question is, to what extent do you personally think, based off of like your experience and your exposure to all of the literature, that will have to change just to manage some of those injuries to be able to keep up with the EVA tasks?
Yeah, well, a lot of that's going to go into the suit design. Well, there's exercise for it. So I think that there is going to have to be, and they already do this, try to come up with an optimized exercise program so to give you the kind of upper body strength and mobility that you're going to need to work in the suit. Then there's, of course, the other thing is to have the lowest suit pressure possible. And so that's going to be an important factor, because the lower the suit pressure it is, the easier it is to work in the suit. And then there's a tremendous into trying to find the best shoulder joints, finger joints, and all the rest to get a suit that really works well. And they have, David Newman and her colleagues have worked for many years on a kind of a skin suit, a suit that's still provides some compression, but is almost like wearing a second skin. So that would be a cool development.
Yeah, my question too was kind of to the point of like the education in the medical background, like before, because like the different like joint mobilization, different things in that nature, to try to help with some of the management of that injury. I was just curious if you think that that's going to increase like in upcoming, like to prepare them apart from exercise, to give them more of that like background that like OT and PT kind of do to prevent.
Yeah, I'm sure that's going to be very important. Yeah.
Okay, thank you.
Sure. Great.
Yeah, well, if nobody else has questions, I can throw up my paper. And
Oh, yes, go ahead. And I forgot, it was Mike Gernhardt. It was the astronaut who was very much involved in developing the pre-brief protocols. Okay, sorry, go ahead.
oh yeah, no worries. Let me get set up. Share that and let me throw my slides up. So hopefully you guys can see that. All right. Take that as a yes.
Yes.
All right. Yeah, so my name is Mimi Lan, and I am a PhD student at the Dartmouth Thayer Engineering School. I'm in my 4th year, and I work with Dr. Buckey on a lot of projects, and one of them is this cardiovascular modeling in microgravity. And one of the things we kind of looked into using this model is jugular vein flow, and how that works in microgravity. So a little bit of background on jugular vein flow. So it's kind of interesting. In about 2019, an astronaut developed a left-sided internal jugular vein thrombosis like 2 months into her stay on the ISS, and it was found during an ultrasound scan performed as part of a vascular research study. They also scanned the contralateral side, the right side, and found that unremarkable. And the clot developed because blood flow in the jugular vein was found to be nearly stagnant. And this image below is pulled from the New England Journal of Medicine article about this. And it shows the thrombosis labeled as TH in the ultrasound. So it was a big surprise to find that jugular flow was decreased, because in space, the jugular vein looks kind of engorged. And so when it's engorged in appearance, you expect the flow to be increased, and that the pressure, mainly that the pressure is increased. And, and IJV clots are very rare. They don't usually happen spontaneously. They usually present in patients with cancer or who have had a central venous catheter. So to find it in an otherwise very healthy astronaut is very strange. And this jugular vein stuff can kind of perhaps tie into SANS, and SANS is called is an acronym for spaceflight associated neuroocular syndrome. It's something that happens with long duration spaceflight. It's kind of this umbrella of ocular symptoms that seem to happen when astronauts stay in space for a while. And one of the weird things is it's kind of an asymmetric, it can present asymmetrically, these ocular symptoms. So, jugular venous flow is reduced, and the asymmetry may also perhaps indicate like a mechanism behind how SANS might be happening. So we use our craniovascular lump parameter model to kind of look into that. There's 2 papers out there if you wanted to read and dig into this more, but so I'll be kind of talking about both of these. There's the first paper that we published was in 2021, and it was just kind of the mechanism for the reduced jugular vein flow. And then we started to look a little bit more into the asymmetric nature of the jugular vein flow based off of anatomical differences. So let's see here. The numerical model. So this is a model built in MATLAB. If you want to play with it for some reason, it's on waitlist.dartmouth.edu. So I definitely encourage you guys to go if you want to download it and run it. It basically comprised of 3 fluid systems. There's the CSF fluid system, the aqueous humor for the eyes, and then just the systemic circulation. And we can do cool things in the model, like change the lower body chamber pressure, add positive or negative pressure. We can tilt the person. They can be supine, prone, maybe head down tilt. And we can also, and very importantly, modify the gravity parameter. So we, in this model, if we kind of focus in on the cranial drainage pathways, we have them modeled as three different pathways. We have the left and right IJV, shown in this like purple and green, I guess blue and green highlight. And these are represented by resistors that can vary their resistance. So the reason behind this is that the jugular veins are compliant vessels, and whether they expand or contract, it's in response to transmural pressure, and the resistance through those vessels will reflect what the transmural pressure is. So that's why we have the funny arrows on top of the resistors. The vertebral plexus, on the other hand, the one coming down the middle, that is a drainage pathway that is not compliant, and it passes through kind of the rigid, bony pathways in the vertebra, and we give it a static resistance, and the value that we've chosen for this resistor is pulled from experimental values published in the scientific literature. So that's kind of the model, how that's set up. Some of the cool results we got from it, we were able to show that the non-dominant IJV flow is more reduced than the dominant IJV flow in microgravity. So what we have here in this funny little plot is on the left side, you have somebody supine in 1G, and you have microgravity in this second on the right-hand side here. And to model anatomic asymmetry, we just settled on a 60-40 split between the two sizes, and 60-40 represents the split of total cross-sectional area between the IJVs. So this is kind of what it comes down to, like 8 millimeters versus 6 millimeters. And let's see. So an interesting thing to look at, let's look at some of these lines. So if you look at the purple dotted line, that is the total jugular venous blood flow in 1G, supine, it's the predominant pathway, and then it decreases a lot in microgravity. And to compensate for that drop in drainage capacity, the vertebral plexus picks up more blood flow. You can see how this yellow line, which is the vertebral plexus path, it increases in blood flow. And if you break the purple line down into its constituent, like dominant, non-dominant lines, it's the red and the blue. So the red line is the larger IJV. You can see it starts with a larger blood flow, and then in microgravity it drops. And similar thing happens in the non-dominant IJV, but it drops to a lower level. If we look at the next slide and look at the kind of the pulsatile, I guess like we actually look at the time sequencing to kind of see how it's simulated in a pulsatile manner. We can see that the non-dominant, so the blue line here, kind of is closer to stagnant. It has these kind of periodic forward flows, but its low points are very close to zero. And the dominant jugular vein also has kind of low points, but it has more positive velocity flow. And this mimics what the 2019 study from Marshall Goebel, what she found when she did Doppler ultrasound on the ISS, that there was some of the astronauts in space, their blood flow had this behavior where it was like overall forward, but with these like periodic no flow moments. So in in short, the model was able to replicate this qualitative behavior that was observed in space. Let's see. So one of the, I think, reasons why our model is able to kind of show this is we include body weight effects. That's one of the unique things about this particular cardiovascular model. And what I mean by body weight effects, I have nice little drawings to show what I mean. If you imagine a lump of tissue with a vessel running through it in 1g gravity, the weight of the physical weight of the tissues will exert an extravascular force on the vessel. And the blood pressure inside the vessel has to kind of fight against that extravascular force to expand. If you take that chunk of tissue and you move it to microgravity, it no longer has to fight that extravascular pressure from the tissue weight, and it can expand more readily and maybe can be described somewhat as like a more compliant system. And if you zoom out and imagine a person lying on their backs on Earth, you know, let's just hypothetically say their venous pressure is 10 millimeters mercury. If you take that person, move them to space, because their venous system has gotten more compliant from the removal of tissue weight, their venous pressure will drop, and let's just say to 5 millimeters mercury. And if we now just take a closer look at how the IJV behaves, or like kind of how the model, how the IJV behavior works in the model, this is kind of the physiological interpretation. So what I'm showing here is 2 IJVs, and look, we're just going to focus on the one in the foreground. So, you know, there is internal pressure in these vessels from the blood that's flowing inside it, and that's represented by these red arrows. Outside the vessel, there is an external pressure that provides a force or an opposing force on the vessel. And then the difference between the two is described as the transmural pressure. So internal minus external equals transmural pressure. There is a relationship shown by this funny little graph that just appeared at the top. The IJV diameter is related to the transmural pressure. When transmural pressure is negative, the IJV collapses. When it is positive, it is more open. That's kind of the general behavior of this vessel. And so when we simulated this, we expected this, I guess, external pressure to decrease, because you go to microgravity, let's say like your neck tissues now weigh nothing, and so your external pressure goes to 0, and that should make your transmural pressure more positive. And but it was kind of a surprising result that what we found was that this internal pressure was much lower than whatever drops we saw in the external pressure, and this actually drove transmural pressure down. And that is how IJV flow dropped. So if we look at this nice little flow chart thingy here on the left, transmural pressure decreased because of this weird relationship I showed, which then drove the IJV diameter to decrease, which increased the resistance, which then drove the flow down. And so that is that's like why IJV flow decreased in the model. And then, and then if you think about the asymmetry part of it, there's basically 2 of these little sigmoidal lines on this plot, and they behave similarly, but have different thresholds for when one closes. So what does all this mean for countermeasures? Let's see. So our model is able to replicate microgravity effects correctly for a lot of things. So ICP goes down relative to supine, central venous pressure goes down, IJV flow goes down, and IOP, intraocular pressure, lies somewhere between supine and prone in microgravity. One of the cool things we simulated was what happens when you apply a lower body pressure to the body and what that effect is on IJV flow. Interestingly, we found that when you apply LBNP, it's a lower body negative pressure, you further reduce jugular vein flow. While if you apply positive pressure, you increase jugular vein flow, which is, more towards the level you want. You want to kind of restore pre-flight jugular flow. And what's concerning about this, in a broader sense, is that lower body negative pressure is a very popular way, or is a way that people like to try to solve microgravity cardiovascular issues. They like to throw LBNP at it. So this kind of suggests that might not be a good idea, and it might actually be harmful. So we can represent this pictorially by using my weird tissue models again. So like I said, if you have a tissue on Earth, you have your internal and external vascular forces, pressures. And if you go to microgravity, you remove the external vascular pressures and it can expand. So what happens when you apply, LBNP is that you further, expand the vessel, which then further drops the venous pressures, and that further drops the transmural pressure, and that makes IJV pressure or blood flow drop even more. And by the same logic, if you do the opposite, you add lower body positive pressure, you can restore some of that kind of like tissue weight effect, and you can increase venous pressures and bring jugular vein flow back towards a higher level. So conclusion being that lower body positive pressure may be the better choice of countermeasure than negative pressure with regard to IJV blood flow and thrombosis risk. Yeah, and that is it. Thank you.
All right, we'll open up the floor to any questions if anybody has any. But if not, we'll go and conclude the session. But I'll give it a few minutes in case anybody has any questions.
Yeah, it's kind of I know it was a lot. So yeah.
Matt, go for it.
Okay, thank you so much, Mimi. It was a really great presentation. Thank you so much. I just had a question about kind of looking of detecting these issues regarding jugular vein flow. I know the example that you provided it was discovered in an alternate research experiment that wasn't related to jugular vein flow that you were specifically looking at. And I was wondering, do you expect there to be more issues within the jugular vein flow that go undetected? And if how would you kind of compensate for that, for those undetected cases, and make up for that and discover them?
Yeah, so it was like, I don't know, I think it was, surprising to say the least when they found that there was that jugular vein thrombosis. And I mean, slowing of the blood flow wasn't that alarming, but the thrombosis was. And so I know that what NASA has done since then is institute a surveillance program, and now they ultrasound often to kind of check for potential thrombosis, because in that study they only looked at 11 astronauts and they found I think like one thrombosis and like one partial thrombi. Excuse my medical inaccurate terminology, but yeah, so it's like if that was how many they found in that small of a group, there's definitely concern that there's a lot undetected, though nothing bad has happened from it, but we don't know if it's just not happened yet. So
Thank you.
All right, Rochelle, it looks like you have a question too.
Hi, thank you for your presentation. It was really useful. I'm Rochelle. I'm an intensive care doctor in the UK. I had a question about your model. So I think you've talked a lot about venous pressure. Maybe I dropped out of the Zoom talk just as you mentioned it, but have you accounted for colloid oncotic pressure and like the protein effect on your on basically fluid shifts inside the vessel in micro-G?
That is a good question. I think we did not take into account, I know like the kind of the interplay between like interstitial water and plasma volume. This model assumes blood does not migrate between those two systems. I think the only fluid migration that happens is between the aqueous humor and the blood. So I think at some point in the model, blood turns into aqueous humor and then is drained from the aqueous humor compartment back into blood. But we do not include oncotic pressures from like the tissues. Though it would be
maybe the next step in your project.
Yeah, I think for sure it's going to be something we want to look at, because that is significant, the effects of plasma and how that changes in microgravity.
Thanks.
Go for it, Jerry.
Hey, Mimi, how's it going?
Hey, good. How are you?
I'm good. Thank you for presenting. It's really interesting stuff. I have a couple questions. I hope that these are not silly questions, but I was a little confused by some of the terminology that you used at the end. So like lower body negative pressure or lower body positive pressure, or you described them like they're maneuvers that you might use. Could you just talk about that a little bit more? What is that?
Yeah. Sorry if I kind of skimmed over it. It's physically this chamber that gets attached to your lower body. And I think traditionally, I'm not really sure when people started to use this. I feel like it was like so it's like a vacuum that's applied to your lower body. So lower body negative pressure is a vacuum applied to your lower body to try to draw blood out of your upper body. And I think it was used in like orthostatic intolerance tests. But it's also thought of as I've heard it described as a poor man's artificial gravity, like like a way to pull blood back to your feet or to kind of, I don't know, replicate some aspects of gravity. So that's kind of why it's been so popular to, oh yeah, and there, thanks Jay. Yeah, there's the contraption. So you can also do positive pressure with that same setup. You can add pressure to the lower body to try to, do other things.
Gotcha. And is that something that is typically on board spacecraft, or is this like only there at times for experimental purposes? Or
I think the Russians have a permanent one. It's part of their, and you can correct me if I'm wrong, Jay, it's like part of their countermeasure program that they use. They call a Chibis suit. Like looks like pants you pull up to your waist, and then with like a thing to kind of cinch around your waist, and then they can turn on a vacuum, and I'm not sure how much pressure they can get. I think maybe 40, maybe even 60 millimeters mercury of vacuum with that suit thing.
cool, thanks. Oh, and my other question was just about what it means to have like a dominant vein. Is that just that people tend to have one vein with a larger diameter than the other, or is this something more complex than that?
Nope, just one has a larger diameter than the other.
Okay. And so I guess I was also wondering, the vasculature in some ways is a little bit asymmetrical the way it's arranged in the body.
Mm-hmm.
Is there anything to that would create, like, I don't know, is that in any way relevant to the pressures in the model, or is it all just like, okay, a person typically has one vein that's a little larger than the other, and that kind of throws everything in one direction?
I think in reality, the actual like anatomic variations would probably play into the flow and pressure characteristics. In this model, though, the goal is to simplify and to like make small changes that we can anticipate and understand. And in the model, it was really just cross-sectional area rather than any kind of like interesting flow direction or other types of anatomical differences, though I know that that would be a good thing to look at for like future work.
Oh, yeah, that's interesting. Thank you.
Mhm. Hey, Rochelle.
Just to follow on from that as well, have you looked at or considered gender differences in vascular tone? Whether I know there's a bit of terrestrial literature on that that we know about in the ICU, but is that relevant for micro G?
I don't know about vascular tone, but I do know that since that whole 2019 jugular thrombosis thing was found, they've really, I think NASA has really keyed in on oral contraceptives as the reason for why that thrombus had happened. And in the astronaut who had that thrombus was on oral contraceptives and is a woman. So, that plays in the gender differences, but I don't know so much about vascular tone.
Thanks.
All right, thank you very much, Mimi, and thank you, Dr. Buckey. I think we're running out of time, but thanks everyone for joining. Next week, we'll be talking about long duration medical planning and then habitat design. And then if anybody's missed any of the previous sessions and wants to look at the recordings, just a reminder, we do have our website at spacemedicine.dartmouth.edu. And we'll see you next week. Thank you.
Thank you, guys.
Thank you.
Thanks very much.